So hello, welcome to this week's clinical case, and again we've got a really nice case, and this case has got everything. Okay, so this is a case of an upper eye 6. It's a crown removal, it's a restorability check, it is a retreatment, it's finding an MB2, negotiating, it's an obturation video, and it's also, like the title says, is that, one of these canals we just couldn't quite get to length. And I think personally, in my practice, I want to show you my sort of rationale and my management of cases where I can't reach all the way to the end of a root canal. It's really important because it's all about consent, okay? And obviously when you see these patients for a consultation, one of the risks that I give to the patients is sometimes we can't get to the end. And obviously they need to understand the significance of that, because what I do say is if you can't quite get to the end on the root canal, there's possibility that there's space remaining that hasn't been shaped, bacteria might remain, this might proliferate and cause failure. But before we get into the case, again, I always say one of the things that always shocks me about these videos is that when I look at the analytics on my business page for YouTube, I notice that up to 2/3 of the people that watch these videos aren't subscribers. So if I could just ask you one thing. It's a super free and easy way to support the channel. It's just a hover over that subscribe button and give it a little click for us. And I promise if you click subscribe, each video I do each week will just get better and better. So let's look at the case. We've got the periapical radiograph here. This is another external referral. And this is a case of an upper right 6 where the patient's crown, I think the contact point was broken. She had a little bit of sort of ceramic fracture and she wanted a new crown. The referring dentist took an x-ray and noticed that she had a suboptimal root canal. And again, we could talk for hours about should you crown teeth that have got suboptimal root canals. But if I could just succinctly conclude that the best thing to do is just to ask the patient. And in this case, the patient was aware that there was a possibility of an apical inflammation around maybe the distal buccal root. I think there is. We could take a cone beam CT scan, but would that be appropriate in this case? Maybe not. Or you could just say to the patient, you can take your risks. I think on balance, I think it's probably best to, especially if the root canal looks awful like this one. This is not a great root canal. It's probably best always to make sure the sort of foundation to the tooth is nice and set, ready to put some sort of expensive coronal restoration on. But in the first instance, during the consultation process, the patient was made aware that, I wasn't too sure about the restorability of this tooth. The crown looked huge. I was concerned about the depth of the core. And I think when you are replacing crowns, the best thing for you to do is just to remove said crown in the first instance, get them in for a cheeky 30-minute appointment, remove the crown to see what you've got left, and then you can kind of shore up the tooth, ready for you to complete the root canal at a later date. And in fact, that's where we pick up with this patient. I'm going to take a sectional alginate in the first instance before we do anything, ready for the temporary crown. Even if the tooth is unrestorable, you can use this to sort of fashion some kind of temporary so the patient can go back to the normal dentist and have the tooth out. And what I like to do when I section a crown, and this might be a bit medieval or whatever, is that I just cut a channel right down the middle of the crown, and then I try and prise away kind of the sort of sections where I've cut down. The problem with this, of course, is that you can damage the underlying tooth tissue. But in my opinion, I just think this is the quickest and easiest way to sort the problem out. I suppose you can use these kind of these crown removing implements, and some people swear by them, but just in my case, I just like to cut the channel and sort of prise the edges up. I also think what's a really good way of removing crowns is that you use an ultrasonic underneath that kind of pried away sort of crown, and eventually what you find is that as you sort of push this crown, it kind of just sort of starts to unsettle a little bit. You can see it kind of moving around, and then it just kind of pops off. But you just got to be really, really gentle with a patient. This can be quite traumatic sometimes to the wrong patients. So you just have to be super, super careful. And obviously you need to be mindful if that crown pops off. Someone needs to be there with the suction to get it, so it doesn't fall down the back of the patient's throat. Because remember, you're not got rubber dam on the tooth. And you can see here that it's using a little bit of ultrasonic action, and the crown is now quite loose in it, and it pops off really, really nicely. And we make an assessment of what's left, and there's a massive, massive core in this tooth. Another concern is the ferrule, and when I talk about the ferrule, I'm talking about the amount of tooth tissue which is sticking above the gum line. And when we remove the core and we remove the decay, the tooth is in a quite a poor state. But actually, I think in this case, I think it is still restorable. It hasn't got a 360-degree ferrule, but we had a conversation with the patient once I'd shored this tooth up, and they were happy to go ahead. I was happy to restore this tooth actually, and I did mention to the patient that if their referring dentist wasn't happy, that I would be more than happy to restore this tooth for them. And I've got quite a good working relationship with the referring dentist, so they know that I'll restore things if they're unhappy to. And it looks really, really deep down there. But what we're going to do is we're going to fashion temporary. We're going to place some Luxatemp into my sectional alginate, and I'm going to push this to length. What I've noticed with Luxatemp, and I don't know if anyone else have noticed this, please comment in the section below, is that when you're first injecting the first amount of Luxatemp, I always feel like that doesn't work very well. So I like to push a little bit on the end of my glove to make sure the two sort of elements are mixed quite nicely. And then when we pull it off, really, really nice. You can see that we've got a temporary here, and there's a bit of flash around the edges, looks a bit rough. What I do is I get the patient to sit up, let them have a little rinse around, and while I'm just adjusting this, and that's a nice kind of little break for them. I don't know if you've ever sat in a dental chair before and sat for these sort of things. It can be quite difficult. And then in this case, I'm going to set this with GI because I know that the sort of retention factors in this temporary crown isn't great. So I'm just going to push this down, and then as the sort of GI is getting a bit tacky, I'm just going to get a bit of floss to kind of get the excess up. And it's not an exact science with these sorts of things, but what I would notice is that once you've put the temporary on, you've just sort of improved the margins. When you come to do your final restoration, the gum settles down and it's not as kind of red and sore, and it's more easier for you to get that kind of margin. Difficulty with margins like this, of course, is if you're doing scanning, it's a tough one to sort of manage. But we're just using these kind of tiny little composite molding instruments just to sort the edges out, and they don't look fantastic, but overall I'm quite happy. And the last thing I want to do is just check the occlusion. Again, I'm worried about this crown being knocked off because it hasn't got a great core in there, so I'm just going to make the occlusion on this crown lighter than it has been. So I'm just going to just sort of polish it down, and also what's important is you polish it up so it doesn't feel like all sort of nasty up there. I always feel like, if you do a really, really great crown for a patient, temporary crown, then they're going to have a bit more confidence in you. And I think there's a lot to say about confidence. You might be quite confident in your own abilities, but if a patient loses confidence in you, it's killer, because they'll just latch onto anything and they'll get the wrong end of the stick. So you've just got to always exude that kind of confidence in patients, and doing good temporaries and being kind and not hurting people always sort of helps that kind of confidence. So we've worked out the tooth is restorable, and now we're ready for our second appointment. So we've booked a full 2 hour for this patient, and straight away we're going to just place the rubber dam, and then I'm going to I use a winged rubber dam in this case. And the great thing about these winged rubber dam clamps is that I like to put the rubber dam clamp onto the rubber dam straight away and then push it straight onto the tooth. I don't like to put the clamp on and then put the rubber dam around, because it just can be really, really difficult. And there's a little bit of a gap between the rubber dam and the tooth. And if you just open up the clamp ever so slightly and give it a little bit of a wiggle, you'll notice now that the rubber dam kind of slips around the tooth and creates like a nice seal. And in this case, we don't need a rubber dam sealer. So it's not got any obvious access in this tooth, because remember, we use this temporary crown, but we'll know we're in the right depth because we'll hit that PTFE dressing. And again, sometimes this can be really, really tough to remove if you haven't opened up the access cavity enough. And also you kind of pull this kind of GP out like it's like a sort of a string, so it can be a bit difficult. And we've got access there, and we can see that we've got 3 canals that have been obturated. And first of all, what I want to do is I'm going to go down the palatal canal. And in this case, I'm actually going to go straight for our rotary files. A lot of the time what I like to do, I like to get the DG endodontic probe just to sort of pick the GP, and then I use a succession of Hedstrom files. But I know in this case that the obturation is very poor and it's not at the working length, so I'm not massively concerned about extruding GP out to the end of this tooth. So I'm happy just to try and waz a rotary file down there. And in this case, the root canal is quite old, and this has the problem is when you do waz a rotary file down there, it can just sort of break things up. So it's kind of a little bit of a cross between getting the GP out quicker if you can, or pulling out in a wanna. And I would say probably in the main, especially if I'm doing centrals, I want to try and pull the GP out in one, and I'm going to use lots and lots of irrigants. And what I've noticed here is the GP isn't being removed in one piece, and actually as I sort of pick away this GP, it's breaking up into little tiny pieces. So I'm going to do some further shaping with a size 20 high flex. Be careful with this file. I've fractured this file a few times doing this. And then I'm going to use a D-finder to try and get to the working length. And then I haven't got a picture of the apex locator here because I just cannot get to the 0 reading. So I'm sort of watch winding this D-finder, and it's kind of getting stuck at the end. So I'm going to use a size 25 Hedstrom to try and attempt to remove some of the GP at the apex. And again, when we use these Hedstrom files, when you know you're doing really, really well, what you'll notice is the Hedstrom file will screw into the GP and you can kind of pull it out. And what I noticed in this case, that there was no real sort of resistance from this Hedstrom file when I was screwing in. So in this case, I feel like I was kind of near to the end of the tooth and there wasn't a lot of GP remaining. And more than likely, the reason why it's not going all the way to 0 in this case is either there is complicated anatomy, or some of the sealers kind of block the end. So I'm just being really, really careful here with the size 10K file. It's super, super easy to fracture these files, so you just have to be really, really careful. And again, I'm just putting the apex locator on. I'm definitely not getting to 0. And in desperation, I'm using this size 10 glide path file just to see if I can negotiate. Sometimes it does slip past. And, it's just not negotiating to 0 at all. And I'm just going to use this really, really long probe. This is actually, I don't know what this probe is called, but it's like a DG endodontic probe. And I'm just kind of slowly trying to pick away the GP away from the wall using a succession of hand files, Hedstrom files, some C+ files. And I just cannot seem to get past a certain point. And again, as I and it's at this point, and it's kind of at this point that I'm getting frustrated. I know that I've remove the vast majority of GP from this palatal canal, but I feel like if I don't move on, I'm going to lose hope. That might sound absolutely ridiculous, but it's really important that you just keep going with these treatments, because I don't know how other people feel, but sometimes I get too focused on things, and then 10 minutes turns into 2 hours, and then you've wasted the whole appointment. So it's just important just to sort of think about maybe looking at the other canals and going back to the canal space that you're having trouble with. And obviously that's going to be irrigant's going to be flowed down that canal for a decent amount of period, and sometimes when you're using the irrigant, this can open up the canal space and you can negotiate. So I'm going to go down the MB1, and again I'm going to use that technique with the size 20 high flex, and in this case this goes to length quite nicely. Again, if you are using this size 20 in quite a few canals, you've got to be careful about fracturing them, because it takes a lot of brunt, these files, and it might be a really, really good idea just to inspect the ends of these files, because sometimes you can see they're unwinding, and when they're about to unwind, they're going to break. So don't be scared to get new files out. And like I said, this size 20 and 25 has gone really nice to length. We get our size 10D finder, we hook this up to the apex locator, and we're right at the end there. So it's really, really nice. And obviously the obturation in this tooth is really, really poor. So essentially what this file is doing is kind of just bypassing the obturation, and we're getting a nice zero reading. Again, we're going to push the hand file out, back it up, and then this is going to be our zero reading, and that is 19.5 millimeters. So it's kind of my normal shaping protocol. We'll use a size 10 glide path file, high flex glide path file to 0 at 19.5 millimeters. Lots of irrigation, lots of recapitulation. And what I mean by recapitulation is you're going to get hand file down to 0 to sort of make sure you're dislodging all the debris. And then we're going to do final shaping with a size 25 high flex variable file, 0.5 millimeters away from the working length. And the same again with the distal buccal. Using the size 20 high flex, again, make sure there's no unwinding of the flutes, because you'll separate this file, and then you're up a different type of creak, the proverbial creak. And again, it's the same with the MB. We're using this D-finder. It's going really, really nice to length. It's kind of pushing past the original GP. We hook up the apex locator. We're through. We're just going to push it back and two, in and out. We're going to push the hand file through, back it up. And then once we back it up, we're going to adjust the stopper and just check that we're still at 0. Because sometimes when you move the stopper and then you check 0 again, you've moved the hand file slightly. And when we pull the hand file out, we can see the working length is 17.5 millimeters. Bit shorter than the other canal, but that might be because of the cusps. And again, it's the same shaping protocol in the DB. We're going to use the size 10 high flex glide path file, and then the size 25. I'm happy to go from a 10 to a 25 because these files were going to length quite nicely. And then I'm just going to have another go at the palatal. I feel like my hope is recharged because I've managed to get down those two canals really, really nice and easy. And I'm using this GP remover, which has got like quite a long end with a little hook at the end, and I'm just trying to sort of try and remove some of this GP, because sometimes you'll notice that you can't get to length and you're getting this kind of hard stop, and then when you remove sort of apical GP, this is then when you get to length quite nicely. And again, I'm just using another succession of size 25 headstrong files just to try and remove this excess GP. And in this case, it's a bit different now when I use these headstrong files, because I've noticed that these headstrong files are screwing into something. So this gives me a little bit of hope that I'm sort of engaging some GP, and this is going to be me pulling it out and possibly negotiating to length. And also, what's a really, really important thing to do is to activate your irrigant, especially with GP. Sometimes this can kind of vibrate the GP out of the canal space and help you negotiate. And then, I feel like, I've pulled out a lot of GP, maybe I'll get to the end, but we get the D-finder, a little bend at the end, and I'm just very, very slowly negotiating, and I just cannot reach zero with my apex locator. And I know I'm not reaching zero because I know how far I've got, and this coincides with the rubber stopper. And again, making that little bend at the end with a size 10K file. And then as we hook up the apex locator, again, it's just not reaching zero. Really, really, really annoying. And I would say we're not bad. We're not too far away from zero, but we're definitely not at zero. And I suspect, like I said before, it's probably complicated anatomy, or possibly some of the sealer is blocking the sort of tube. And the furthest point reached is 19.5 millimeters. And we're going to use the last resource. We're going to use some solvent. This is orange oil. What I'm going to do here is I'm going to wick out the remaining sodium hypochlorite. Again, I don't think sodium hypochlorite reacts negatively with this orange oil, but I just don't want to be too sure. And then I am just going to irrigate the canal space with this orange oil and let it really, really soak in. And now I'm using a size 8 C+ file. So these C+ files are stiffer, and they sort of keep their shape more. And then what we're doing is making a little bend at the end. I'm just going to kind of sort of feel around for this kind of catch. And the amount of times that I've found the catch is more often than not. But again, in this case, I just cannot for the life of me reach past this furthest point, reach this 19.5. And then our kind of last ditch attempt is to use a size 6 C+ file. And although these C+ files are quite stiff, but I think these size 6 C+ files are just a bit too bendy to kind of get past these tough kind of anatomical difficulties. And then the very, very, very last forlorn hope, I'm going to use a size 8 to try and negotiate, and I just cannot get to the end. And it's at this point I'm thinking to myself, I could carry on, I could fracture a file, and this could just get me into more trouble. So we're going to say to ourselves, it's probably best that this is as far as we can get. And I think it's really, really important to demonstrate, or just to show how I manage cases where I just can't get to length. And of course, this is a really, really important sort of example of why you should do the consenting process, because during the consenting process we talk about the risks, and one of the main risks that's always highlighted to a patient is we can't get to the end, because the inside of the tooth is infinitely complex. And I say that for every single tooth, from teeth that look really, really obviously sort of open on a periapical radiograph, and to teeth that are obviously calcified. What we do is we just sit the patient up and we have a conversation, and I would say 99.99999% of patients where, I can't get down one of the canals, and we're sort of in the kind of vicinity of the canal, but we just can't quite get zero. And we say to the patient, do you want to filter as far as we can get, or, do you want the tooth out? 99.9999999% of the patients go, yeah, let's have a go. But the most important thing is obviously you consent the patient. You've obviously set the patient up to be thinking about not getting to the end because you've consented them at the consultation process. But the worst thing to do is kind of make that decision on their behalf, because obviously they're not then involved in the consenting process, and if it all goes wrong and the patient didn't know, well, you're kind of in trouble. And also, it's not the right thing to do. I think it's important for patients to make their own decisions about their own teeth, and I think if you say to the patient, do you want to take the risk of us filling the tooth and see how we get on, and it doesn't work out and you haven't asked them, I think you're in trouble. So we know we can't get to the end of the palatal, and what I think I did notice is as I was irrigating and shaping these 3 canals, we've noticed there's an MB2 orifice. And I noticed that it's obvious and it's quite wide, so rather than negotiating with some hand files, what I'm going to do is I'm going to take a size 10 glide path file down this canal orifice, and I'm not going to push this glide path file too far down, and what I'm doing is I'm just trying to open up this canal space, and I'm also going to use a size 20 as well. Again, I'm not going to push it too far, I'm just opening up the canal space, opening up this orifice. I'm going to do a bit of irrigation. So at this point I'm suspecting the MB1 and the MB2 join, because when I irrigate and aspirate, both the canals irrigate and aspirate at the same time. So just to check this confluence, I'm going to take a GP point and place this to length in the MB canal, and then I'm going to get a hand file and I'm going to place the hand file in the MB2 canal. I am then just going to very, very gently push this hand file to length, and as I sort of push it down the canal, I feel like a kind of a spongy feeling, and that's the tip of the file sort of touching the GP cone. I'm going to adjust the stopper, and as we pull the GP cone out, we can see here that a mark has been made on the GP cone, and we know this is at which point the two canals join. And in fact, because we move the rubber stopper with the hand file, we can see that they join at 16.5 millimeters in the MB2. So this is great. We know where these two canals join, so I'm just going to use a size 25 variable height flex up to this point, and this is all of the canals shaped successfully. So, you know, arguably one of the hardest points of the root canal treatment all completed. And then we're ready to do our cone fit radiograph. So we're going to check that all our cones are going to be at the correct length when we come to obturate the tooth. So I'm obviously just going to measure the cones, fit them to length, and what I notice here in the DB, I've measured the DB cone and it just isn't quite going all the way. And again, the worst thing to do here is just to go, oh, you'll be all right, we're near as damn it. But you know what? You know, you leave, if you don't obturate a tooth correctly, you're going to leave space for bacteria to proliferate. And the only thing to do here is just to pull the GP cone out, re-irrigate, reshape. And you can see here that now when we push this GP cone to length, after reshaping the canal, it fits nicely to length. And then we have a little look at our cone fit radiograph, and we can see here that all of the cones are fitting really, really nicely to within the radiographic apex, or the acceptable level of the radiographic apex. I also want you to just to focus your attention on the palatal here. You can see that, you know, we didn't get to the end on the palatal, but the GP cone is pretty much near to the end, and this is an indication that, you know, we've cleaned and shaped the vast majority of this canal space. And it's likely the reason why we didn't get 0 on the apex locator is because of, you know, really, really complicated anatomy, or again, like I said before, this sealer's probably blocked the portal of exit. So overall, I'm quite happy. Our final irrigation protocol, we're going to remove the GP cones. We're going to put them in a disinfector, because remember the GP cones aren't disinfected. We're going to do a first rinse with sodium hypochlorite activated, a second rinse with EDTA to open up all the tubules, and then a final rinse with sodium hypochlorite just to get the sodium hypochlorite all into those nooks and crannies, and it's all going to be activated. And then obviously we're going to dry with paper points. And then we're ready to obturate the tooth. I'm going to do a little bit of a different technique with the palatal. In this case, I know that I haven't got 0, so I haven't obviously got patency with this canal. So in this case, what I'm going to do is I'm going to fill the canal space right up with a bioceramic sealer all the way. And then I'm going to get my GP cone and I'm going to really, really push this home. I'm not going to be gentle here. And more often than not, if you don't get patency with a certain canal and you fill it really, really up to the brim with bioceramic sealer and you push the GP cone to length and then you really, really push it down, really compact the GP cone, you'll notice that the high flow of the bioceramic will flow into those sort of complicated lateral canals, those portals of exit, and you'll see this kind of beautiful kind of sort of fanning of the bioceramic that goes into all the little nooks and crannies. You know, just don't be gentle with this. Really try and push that and condense that sealer down. However, in contrast with the other with other canals, they are patent, so you don't want to use that technique. I'm just going to use a more traditional single cone technique where I just fill the coronal to mid-third with Bioceramic. I'm going to then get a hand file, and I'm going to introduce this hand file to almost to length to introduce the Bioceramic to the full length of the canal, and then very, very gently push the cone to length, and then just sear it off with a heated plugger. And then when we look at the post-op radiograph, I'm really, really happy with this. It looks really, really nice. As before, we can see that all of the obturation is to within the within the acceptable level radiographic apex, which is between 0 and 2 or 3 millimeters. And I suppose if we draw our attention to the palatal canal, there's an argument to say maybe there's been a little bit of extrusion of sealer there, and possibly, we've by pushing quite firmly down and using lots and lots of Bioceramic, we've managed to seal that seemingly non-patent canal. But it's hard to say. But overall, I'm quite happy with this. I suppose, there's an argument to say there's a lot going against this tooth. This tooth's a re-root treatment. It's got a questionable prognosis, and also we couldn't seemingly get patent on one of these canals. But overall, we've had an open conversation with the patient, haven't we? We've basically told the patient all the warts and all problems with the tooth, and they've made the decision. And they've made the decision to try and save the tooth. And in the end, if it's acceptable, this is if it's an acceptable tooth to save, then I'm happy to have a go. And then we're finally ready to just temporize the final tooth. I'm not going to place a composite core in this tooth straight away, mainly because I'd never get the temporary crown off. So in this instance, what I'm going to do is I'm going to seal off the GP cones. I'm going to seal off the orifices with a light cure GIC. Then once that's all sealed off, whatever you do with the coronal restoration, when you pull this temporary off, you're not going to reintroduce bacteria into the canal spaces. And then what I'm going to do is I'm going to fill this with PTFE and GIC. And of course, the temporary's been cemented on with glass ionomer. And I think it'll be easier for the referring dentist for me not to place a core in this tooth and just to remove the temporary and then place a core and do the crown prep in one. And overall, a really, really great case. As always, we always choose the best cases. If you have any criticisms or you don't agree with anything that's been done in this case, please, comment in the section below. If you have any questions, again, please comment. I'll try my best to answer all questions. I've also asked a couple of questions in this video, so if you've got the answers, that'd be fantastic if you could let us know. And please, if you love this video, please like and subscribe. It's the easiest and free way to support the channel. And if you really, really like the channel, there's a membership program, a YouTube membership program, and essentially it's a small monthly fee, and you get early access to content. I usually work about 2 to 3 weeks ahead with the content. So if you really, want to see the videos early, you can see them, and it just keeps me independent. And I'd like to say thank you for watching, and I will see you in the next video. Bye-bye.